warfare, and I'd like to introduce to you Jim Buttery. He's the inaugural Professor of Child Health Informatics at the University of Melbourne. He's the Chief Research Information Officer and Infectious Disease Physician at the Royal Children's Hospital in Melbourne and Head of Epidemiology Informatics at the Murdoch Children's Research Institute. And he will speak to us on epidemiology of winter respiratory infections, incidence across the ages. Jim.
Thanks very much, Gary, and I'd also like to join him in thanking the organisers for the invitation to present today. So, first of all, these are my disclosures. So what I'd like to talk about today is covering three different areas. The first is discuss age-related viral epidemiology. What do we see in terms of our viral multiplex PCR results when people are presenting with respiratory illness in the population. Then talk a little bit about the direct impact across the ages of these diseases clinically. And then finally talk a little bit about our broadening understanding of the impact of viral infections on health conditions that we don't automatically think about direct consequences of viral respiratory infections. So let's make a start. So normally I scan the published literature to prepare for these talks, and approximately 4 days before I started preparing for this talk, a superb systematic review came up on a preprint server. So this is not published yet, but it's on a reputable preprint server from a group headed by Alexandra Hogan at the University of New South Wales. The first author is Muskan Gupta. It's on MedRx, and other colleagues include many people who you know extremely well: Betty Liu, Christine McCartney, and James Woods. So this publication answered the exact topic of today's talk, so I'm leaning heavily on this. And essentially what it is a systematic review and meta-analysis of largely observational studies describing the epidemiology in 21 high-income countries across the different ages of individual respiratory viruses, acknowledging that when you start looking at respiratory viral epidemiology studies, we're largely limited by the tests that we use. And most countries, high-income countries, use multiplex respiratory PCRs, in other words, a panel that gives you a different sorts of viruses. And what they focused on were the most commonly included across the different countries, which were influenza, not surprisingly, RSV, human metapneumovirus, and parainfluenza virus. Once you leave those, there's a lot more variation as to what the panels include. So they focused on those four main viruses. So it included 61 different studies from more than 14,000 different individual records and more than 500,000 assays performed over this time. And we'll get back to the results of the systematic review first, but this is Victorian epidemiology, and what we have during the winter respiratory peak is, if you like, a cascade of viral epidemiology. And typically, not always, but typically, RSV is the first cab off the rank, and that surges first, typically in May, June, sometimes can start a little bit earlier, and then that's then followed by the influenza peak. And then underneath that and at a lower level, you get a more stable but nevertheless slightly later peaking human metapneumovirus and parainfluenza virus. And this is not including the other respiratory viruses that we also see, including adenoviruses, the much more complex enteroviruses, which includes rhinovirus, the common cold virus, but also includes other enteroviruses. And typically our tests can't tell the difference, which is one of the reasons that's not featured heavily in this. And this relates to work done by Rana Sawiras as part of her PhD, which I'll touch on again later. So coming back to the systematic review, what it showed really convincingly was that viral dominance in terms of what we find when people are presenting to healthcare and we do respiratory assays has a bimodal peak of non-influenza dominance at each end of the age spectrum, with influenza dominating in the middle. So when you look at infants, there's a real dominance of RSV in particular, but also human metapneumovirus and parainfluenza virus in infants. And then as we move to school-age children and adults, influenza takes over as the dominant virus. And then surprisingly, even though there's no denying the significant impact of influenza on older adults, at a frequency level, we start to see the emergence of the non-influenza viruses in terms of frequency, particularly RSV, which clearly is indicated by the recent implementation of the Arexvy vaccine in the 75 and over group in Australia by the federal government. And so, although there's still a significant impact of influenza, at a frequency level, RSV, HMPV and parainfluenza start to dominate again. So early life, as we've already discussed, especially the 0 to 6 months, is dominated by the non-influenza viral trend. The vast majority of the hard work is done by respiratory syncytial virus, or RSV, noting that these studies occur in high-income countries where there's many maternal influenza vaccination programs that may also have had an impact on these results. So in Australia, approximately about 50% of women are vaccinated during pregnancy against influenza as well. But there's no question that RSV is the dominant virus we see in infancy, which is reflected in what we see presenting to our hospitals, in particular with bronchiolitis and associated diseases. But human metapneumovirus comes a distant second, but still a significant second, followed by parainfluenza virus. So in the first 6 months of life in these settings where there's a reasonable uptake of maternal influenza vaccination, influenza accounts for less than 10% of what we find. And then we hit the transition phase, which is school-age children, where non-influenza drops from 90% down to about a third of what we find. And that's roughly equally distributed between RSV, HMPV, parainfluenza. A little bit higher in the younger adults, 18 to 64. I note I'm saying younger adults nowadays. And the relevant impact compared to the non-RSV in children and adults of non-influenza viruses decrease, with influenza dominating during this time. And then as we move into older adulthood, we see the resurgence of the non-influenza viruses again, in particular RSV, but about half of HMPV and parainfluenza virus detections occur in the older adults, and almost 60% of RSV detections occur in the older adults. So even though the peak is higher in the children under 6 months of age, clearly you've got a lot longer to accumulate detections during your 65 plus years. And so what we do see is that severe outcomes also concentrate at the extremes of the lifespan, not surprisingly. So in early life, we see the impact of respiratory viruses manifesting as bronchiolitis and pneumonia. And we've just seen a conference describing the massive impact of the different RSV interventions on those clinical outcomes, which is a fantastically successful implementation of both maternal vaccination and the monoclonal nirsevimab implementation on improving those outcomes in early childhood. There's relatively low hospitalisation rates subsequently through childhood and then into early adulthood, until we get to older adulthood, when the severe outcomes start to climb in terms of respiratory disease, and that continues to escalate as we get older. And that's certainly reflected by the vaccination policies for both influenza and also for RSV. So how does Australia compare with other countries in the world? And interestingly, noting that Testing behaviours vary around the world, as do some of the vaccination policies vary around the world, but it's pretty similar in terms of that bimodal age spectrum. No matter where you look, it's reflected in other countries around the world. So Australia, compared to the US and the UK, we seem to have an higher early life peak, but in every one of those settings, there's the peak at either end of life, with differences mainly seen in the 20 to 64-year-old age group, where interestingly Australia seems to do better, at least on viral detections. Now, I need to emphasise that this does not necessarily mean clinical outcomes, because it's influenced by how people behave in terms of testing when people present with clinical outcomes. So if you're in a setting where there's less testing of younger adults, for example, for respiratory viruses, you're going to artificially lower that rate of detection per presentation. So to put that all together, what we can see in terms of severe disease, it's mirroring the peak of unvaccinated pathogens. So, and until very recently, and so the period that this systematic review was following was prior to the implementation of RSV, both in pregnancy and in early infancy. So we can see that the highest peak aligns beautifully with the dominance of RSV, human metapneumovirus, and parainfluenza virus in infants. As we move into later childhood and early adulthood and middle adulthood, the peak really is reflected by influenza, and then as we age, that secondary hospitalisation peak aligns well with the resurgence of non-influenza-based viruses. So, moving on to the ripple effect, if you like, of viruses. So we know well the direct impact of most viruses. We know that they can give you a snotty nose, they can make you feel like rubbish, they can give you a headache, depending on the different viruses. We've got a good understanding of the common features of viruses. And we've got a reasonable but surprisingly not great understanding of the more severe impact of viruses in terms of hospitalisations, pneumonia, and we're beginning to get a feel for possibly the impact of viruses on secondary bacterial pneumonia. And in fact, during the conference, we heard some presentations regarding the impact of potentially RSV and other viruses on the longer-term probability of being admitted with community-acquired pneumonia during the subsequent 12 to 24 months, including some really interesting data from Queensland that was presented during the meeting we've just had. So, to help understand the less common impacts of viruses, we set up a platform called SnotWatch that's now broadened into a platform called eHomo that's being capably managed by Aaron Weinman in our group, and was really led by Rana Sawiras in her PhD and has since been further expanded to use ecologic data at a statewide level to how can we understand the further impact that common pathogens have but those health impacts are less common. And so what we've done for SnotWatch is we've taken pathogen test data from almost every public laboratory and a large number of the private laboratories in Victoria. We've combined that with non-linked health outcome data from hospitals, emergency departments and primary care. And using spatiotemporal methodology, derived associations between what's the probability of being exposed at a spatiotemporal level, in other words, time and place, of high density of a particular pathogen with the probability of subsequently developing that health outcome. And so coming back to Rana's study, the first study Rana did for her PhD was really looking to see how do febrile seizures in our community correlate with viral activity in the same time. And what Rana was able to show was that febrile seizures were significantly associated with influenza, which has been found previously, but also RSV and in particular RSV, which was novel. And to a lesser extent, human metapneumovirus. So these common viruses are having significant uncommon adverse events, but effects on our health that we typically haven't included in our assessments of the impact of these viruses. And as part of the rest of Rana's work, she also took the opportunity of during the COVID pandemic when we started, many of you may remember, we started seeing people coming in with this concept called COVID toes or chilblains. And in particular, for the first time, we started seeing children coming into emergency department with chilblains. And what Rana was able to do using in collaboration with the Polar GP data collaboration to show that COVID-19 infection was closely correlated with the probability of presenting with chilblains. And interestingly, that association was much stronger in children than it was in adults. She looked at asthma exacerbations presenting to emergency department and, not surprisingly, found a lot of viruses were associated with that, as well as pollen counts, humidity, and for some reason, the onset of school term 4 that we still can't quite explain. The uncommon but severe disease of Kawasaki disease in children, she was able to show an association with both RSV and human metapneumovirus, and that's in the RSV association has subsequently been validated in the Republic of Korea as well. And then finally, somewhat surprisingly, when there was an outbreak of a non-respiratory adenovirus in association with acute hepatitis in Europe and North America, we did an analysis using respiratory viruses, so not the same adenovirus. We didn't find an association with respiratory adenoviruses, but interestingly, we did find an association with RSV and enteroviruses. So the next step, so what Rana did was look at common childhood viruses and uncommon or reasonably common childhood health outcomes. And Tu Nguyen, as part of her PhD, has taken that a step further in looking, one, at important adult outcomes, but two, taking the next statistical step and saying, not only is there an association, but how can we quantify that association? So we can estimate what proportion of myocardial infarctions and, in a subsequent study, stroke are potentially attributable to those individual viruses. And so again, to use the same methodology, taking respiratory PCR tests from 6 laboratory organisations and admissions data in Victoria for myocardial infarctions, use the statistical methodology to derive an association with a number of viruses. And what Tu has been able to show is that influenza, enteroviruses, and again, enteroviruses are a mix of rhinovirus and other enteroviruses, and RSV are associated with acute myocardial infarction. But importantly, there's a lag effect, so it's not the same week that you get RSV necessarily that you get an AMI. And what we found is that the week, up to a 3-week lag between getting the infection and then subsequently developing the infection, and that seemed to vary a little bit by the virus. And so what Tu was able to do in the quantification part of the study is to show that 1 in 12 acute myocardial infarctions are associated with an acute respiratory infection. Now, that doesn't mean they cause the AMI. It means in people with underlying predisposition, the acute respiratory infection was seen to trigger the infection, the myocardial infarction subsequently, which translates in Australia to about 1,000 cases of acute myocardial infarction annually. The strongest association was with enteroviruses, and then the next strongest was with RSV, and then influenza. So, in conclusion, winter respiratory viruses differ according to your phase of life. There's a bimodal non-flu dominance with influenza dominating in between that. It's important to remember that there's significant co-circulation. So adenovirus, which was not included in that systematic review, is the most commonly, is the virus that's most commonly found in tests where there's more than one virus positive. And so it's not completely easy to tease out the individual contribution of viruses, especially adenovirus. It's also important to realise that we have better impact data for vaccine-preventable viruses, which makes sense because we need that impact data so that we can justify implementing a vaccine. And we're only just beginning to understand the broader effects beyond respiratory disease of these common viruses. And finally, I'd like to thank this fantastic team at the Centre of Health Analytics and Epidemiology Informatics. Thank you very much.
Thank you, Jim. An amazing talk, a hell of a lot to unpack there. I wonder if there are any questions on the floor, from the floor, but I'd like to ask one myself first. Just about, we heard a lot about the impact of maternal immunisation for RSV at the conference just gone. I wonder if you now expect those numbers to dramatically drop as predicted by others, or what your view is of that. And also if you have any thoughts about when adults should get an RSV, you know, what time, what age, how many? Has anyone gone that far yet?
Thanks very much. I think the undeniable success of both the antenatal RSV vaccine and neonatal nirsevimab are going to exhibit their greatest impact in the first 6 months of life. And I think it's important to realise that some of these secondary health outcomes occur slightly later in infancy. So both febrile seizures we typically don't see until beyond 6 months of age. So I think we will see an impact, but I think where we would only expect to see that impact probably more so with nirsevimab, that may persist a little bit longer, and obviously any high-risk children that are receiving it in the second year of life. And so whether the numbers are going to be sufficient for us to be able to demonstrate a reduction will be interesting. I think there's a chance, but it's going to be more complex simply because of the later onset in life. Where I think we're more likely to see impacts that haven't yet been fully delineated, there's some suggestive evidence from France, is some of those aligned respiratory outcomes like otitis media. And I'm really looking forward to doing that analysis in Victoria. I don't have any additional recommendations regarding implementation. I know that the implementation is a complex decision regarding cost effectiveness, and as the probability of severe outcomes increases with advancing age, if you like, the bang for buck for the RSV vaccines increases, and hence I think why 75 was chosen. Would they work below 75? Absolutely, but on a cost effectiveness level, it's you really need that impact to be able to make those calculations, and I think we'll probably see the age dropping as things progress.
Is there any other questions in the room? Ian? Just here. Yeah, you've got to go up there. Oh, sorry. I didn't see you there. You go first.
Thanks, Jim. Really great talk. I'm just wondering about testing behaviour, because you mentioned that as one of the main drivers. And I'm wondering if you have any thoughts on the use of rapid diagnostic tests and whether there's a differential between use of those in adults that may underpin some of the differences that you see between, say, Australia and UK in terms of more testing in young children and more disease there.
It's a great question. So I'll tell you what I know, first of all, which isn't exactly the answer to your question, that historically we've seen testing rise in the last decade or so, certainly in Victoria, in all age groups, but differentially a higher rise in adults than we've seen in paediatrics. Bizarrely, if you're at a hospital level, which is not where the majority of testing occurs, the majority of testing occurs in the community, it's very institutionally dependent. There's almost a philosophy as to whether you test or not, because, quite frankly, it's uncommon that it changes your immediate management of children. Then to come back to your question, I think probably the increased availability of point-of-care testing in other settings may help inform that. What I'm less aware of is knowing how well that feeds into available data. Because there's always a risk with point-of-care testing, as we saw when we moved to self-testing for COVID, is that that data doesn't get collected.
Nice talk, Jim. The elephant in the room in the Gupta study is obviously SARS-CoV-2. It hasn't been taken into account. Or did they have anything in their discussion which place caveats on all of their analysis?
Yeah, it's a good question. I think because it was overwhelmingly pre-COVID, and I think they mentioned that one weakness is it was specifically excluding COVID, and we can't deny that. I guess one of the things I find immensely complex about that is the sort of forever shifting sands of different COVID strains and their impact coupled with the different vaccines. And I think there's an undeniable impact of COVID that is ongoing. And I have to be honest, if I was doing the systematic review, I probably would have left it out as well, because it would have introduced a level of complexity, not because it's not important, just because it's so complex to try and unravel. And I think it probably deserves its own review.
Thanks for the talk, Jim. I just want to follow on what Gary was talking about earlier.
Just a minute, Paul. If you could just a little closer to the microphone, because people can't hear online.
Sorry. I had to raise it because Ian's quite short. Some of the initial concerns about the use of RSV in the 60 to 74 related to surprising GBS numbers in the phase 3 studies, and I think that was part of the US decision, and I assume part of the Australian. I mean, the consensus statements now suggest that we're looking at, 7 per million excess with Arexvy and 9 with the Brisvo, and so it really is a very, very small risk. If we take that risk out, does your data suggest that in fact there is significant disease in the 60 to 74s, and we should be looking at reducing the age at which we start to provide in Australia?
Thanks. It's a good question, and clearly the other relevance of Guillain-Barré syndrome is that the background incidence is very age specific and quite dynamic in terms of that, and so we assume that the attributable risk, so the absolute increased risk, should there be any from the vaccines, is also very age dependent as well, in correlation with that background incidence. So to probably in a fairly complex way of avoiding answering your question directly, because it's a really good question but a really hard question, is that I think once you've done that age-adjusted excess risk, which is going to be tiny, but there'll probably still be a little bit there, I think the risk itself is a low justification not to move it down. I think it's, at least in Australia, it's still overwhelmingly driven by cost effectiveness. While safety can't be ignored, the absolute risk is tiny, and it's still going to be a cost effectiveness implementation decision that will be driven predominantly by the impact of viruses, which is undeniable but increases the older you get. And so I think the safety component, as much as I love talking about safety, is a relatively minor consideration in the overall implementation decision.
Jim, it just remains for me to thank you very much again. If you could all thank Jim. Thanks very much.